Welcome to the Rocky Mountain MS Center Spring Summit for 2021, and also welcome to the Rocky Mountain MS Clinic at the University of Colorado Hospital, where I'm at now. So we were going to have a session to answer some of the questions submitted by participants in the conference today. And I will address a few, and my colleagues are going to address other ones, and we'll come back at the end and have a brief joint discussion. So some of the questions that were assigned to me included questions about whether patients should consider being on disease-modifying therapies, even though they already have significant disability. So one patient asked, I was diagnosed in 1979 and I'm walking with a rolling walker now. I've been advised to take MS medications, but the new medication was not available when I went through the relapsing remitting phase, and I'm now in secondary progressive stage. Should I be on medication? So there's a second question that has the same basic tenor that has to do with optic neuritis, which resolved after 9 months, but now they're wondering, should they be on therapy? And there's a third question that's related to this that has to do with, are our lives shortened from having MS and never having been on disease-modifying therapies? And these are all relating to the same issue, which is, when is it appropriate to treat and when is it not? The reality is that we can't predict how any single individual patient is going to do on any given therapy. All we can do is tell you that when we treat 1,000 patients in a phase 3 trial on drug X, the chance that they would have these outcomes is X, Y, and Z. So when we are selecting therapies for patients, we're trying to look at therapies that have the best chance of minimizing adverse outcomes, as well as looking at their risk profile to see whether we can justify using that therapy. So it's not how much disability you have now that should determine whether you should be on therapy or not. It's if you're still in the active inflammatory phase of the disease. If you're below age 55, in my view, you're still in the active phase of the disease, and you should be on therapy to try to prevent any further loss of function. Even if you're doing really well, you maybe still should be considering being on these therapies, because again, we can't predict what's going to happen to you in the future, but the therapies we have now are very effective and can minimize your risk of suddenly having an event that changes your life. In terms of the question about shortening your lifespan, absolutely. Not being on therapy does pose a risk for shortening your lifespan. Prior to 1993, the average lifespan of MS patients was about 12 to 15 years shorter than the rest of the population. And it wasn't that they died necessarily of MS, but they died of complications of MS related to infections, because as you gain disability, that increases your risk for pneumonias, bladder infections, and other things that ultimately can lead to death. However, a recent study that I mentioned in my talk demonstrates that the lifespan of MS patients today is approaching the normal lifespan for people without MS. And so we have very good evidence that by using immunological therapies appropriately, we can minimize the chance that MS is actually going to shorten your life. So yes, I would say that that a patient's thinking about whether they should be on therapy related to lifespan, the answer is probably yes. So another question has to do with, why does there seem to be more treatments or drug therapies coming to the market for relapsing remitting MS versus primary progressive MS? Well, there are a couple of reasons. The first reason is that 85% of patients with MS start out with relapsing remitting MS. So there's simply a larger population. The second reason is that the outcome measures that we use in relapsing remitting MS have to do with decreasing relapse numbers. And that's a nice concrete number that you can measure, and statistically, it's relatively easy to show a treatment effect. So the studies are easier to do. And the third reason is that patients in earlier phase disease, such as relapsing remitting, tend to have a better response to the therapies overall. And we have lots of data showing that the earlier we treat in the disease course, the better the outcomes. So those are the main reasons. However, having said that, we have many ongoing studies in progressive forms of MS, both secondary and primary progressive. They're a little bit harder to do because we're looking at the ability of people to walk, which is a little bit harder to measure in a quantitative way, but they are very active. It has been harder to show that a drug works in progressive MS, so many more of the studies have failed. I don't think it's because they don't work, but it's because on the way that we measure the outcome, their treatment effect is relatively small, so it's hard to see. So right now, though, the way that we think about MS here at the Rocky Mountain MS Center and the way the FDA thinks about MS has evolved. And now we're focused not so much on whether you're progressive or relapsing, but whether you're in the active phase of the disease or not. And if you think you're in the active phase of the disease, then we will treat you, but we'll still treat you with the most highly effective therapies we have, which tend to work in all forms of MS anyways. There's another question that has to do with the patient who said that they have been diagnosed for more than 10 years with MS, but should they be checked for the antibody markers for diseases such as neuromyelitis optica or anti-MOG antibody syndrome? Now, that depends on whether your MS is typical or not. If you're having a relatively typical course and you're responding to the current therapies, probably is not necessary. But if you have an unusual MRI or particularly aggressive disease or disease that causes more cognitive problems or a combination of vision and spinal cord problems, then yes, it's probably reasonable to check into those because the treatment for those diseases is different than it is for typical relapsing remitting MS. And then there's a question that has to do with, I've been receiving tysabri and had no relapses since diagnosed 8 years ago. Should I change to ocrelizumab or Ocrevus? And what are the chances of relapses during the transition? Well, if you're JC negative, tysabri is a very safe and very highly effective therapy. So if you want to change, it depends on what your reasons are. If it's to only have to have infusions twice a year rather than monthly, that's a reasonable reason, and certainly reasonable to change. Or if you turn JC positive, certainly changing would be important. But outside of that, there's not another particular advantage of ocrelizumab over tysabri, other than that if your insurance stops your coverage on tysabri, you have this risk of a rebound MS disease activity that we don't have with Ocrevus. So if your insurance delays your next infusion of Ocrevus, that's not a big deal. With tysabri, it's a very big deal. Chances of having breakthrough MS due to going off tysabri if you transition to ocrelizumab or any of the other anti-CD20s is very low. We would urge you to get your first dose of Ocrevus at 4 weeks after your last dose of tysabri. And in that situation, we've never had a case of breakthrough disease. Okay. And then the last question I'll deal with has to do with an article that suggested that the messenger RNA vaccine technology that's been developed for coronavirus might be relevant to treating autoimmune diseases like multiple sclerosis. And the answer, yes, I think it's quite relevant to that question. We actually tried using a vaccine approach to MS. We're using a DNA vaccine almost 15 years ago. And that's they failed to show benefit. It was safe, but we weren't able to show benefit. But I think it doesn't have to do with the technology as much as it has to do with what protein you're going to use to try to re-educate the immune system to respond differently to a protein in the brain. And at that time, we used myelin basic protein, which I don't think actually is a good target for immune regulatory therapies. But the mRNA vaccine technology is very powerful, very simple to use and develop. And I do think that there will be groups that will be moving forward by developing a messenger RNA that encodes another protein from the brain that then gets injected into the muscles in your arm, which causes the protein to be expressed in a normal, healthy environment, in which case the immune system should recognize it as a self-protein and hopefully then carry that response over to the brain and shut off the inflammation in the brain. So I think this is great technology. I think it's potentially useful in many different areas, and is although the pandemic has been an unfortunate experience, it has actually helped this particular area of medicine develop very rapidly. So again, thank you for your time and attention.
I think there's a very succinct question that I'd like to kind of start off with, and it goes, COVID and MS, what do we need to avoid the most? And I think to some extent we're stuck with both. So especially for our MS patients, I think that the questions become around treatment of MS and then the vaccine for MS, or sorry, the vaccine for COVID. And to some extent, maybe this is sometimes one of those questions that's better answered by the safety of the treatments for both of these conditions. And what I mean by that is COVID for many people is a very mild disease. Unfortunately, it's hard to predict who it's going to be a bad disease for. And it kind of goes the same thing for MS. And when we look at the treatments, I think the important point is to realize that the treatments are very safe and much safer than the risk that comes from these diseases. What I mean by that is we can see some episodes, some flares, and I'll talk about these a little bit later, about attacks kind of starting after the COVID vaccine. But when you look at the numbers of these, you're talking about events that happen 1 in a million. Versus if you get COVID, the mortality rate's still over 1%. So it's 1 in 100 versus 1 in a million. I'll take the 1 in a million any day, just playing the odds. From an MS perspective, the treatments are very safe, and the treatments don't increase the risk of COVID too much. And the presentation talks a lot about B-cell therapies and a potential mild increase of bad outcomes of 2 to 3-fold. We have a few questions around getting the COVID vaccine and whether it's offered at UC Health. And I'm happy to report that, yes, the vaccine is available through UC Health. If you've not received a questionnaire at this point, please reach out to the clinic. Because at this point, at least in the state of Colorado, as of already about 2 weeks, then we will be offering COVID vaccines in the state of Colorado to everybody. MS patients, due to their neurological condition, for most of our patients being immunosuppressed, have 2 reasons to have been vaccinated and would have fit into groups that really kind of started qualifying for vaccinations since early March. And UC Health has vaccinated about 1/4 of the state of Colorado at this point. So at this point, everybody qualifies for the COVID vaccine. I have a very great question about stopping treatment. So the alternative, if we're worried about disease-modifying therapies, is can we stop treatment if they put us at that much risk, especially if you're high risk and of getting COVID. Your healthcare provider, for example, talks about going on public transportation, and maybe low risk of an MS relapse because of a lot of the same things that Dr. Gross already mentioned about being able to stop treatment. And what we're finding is that the risk associated with these conditions, for the most part, are so low that we haven't really changed much of our recommendations around stopping treatment, specifically due to COVID. But if you meet a lot of the same criteria around the DISCO-MS study, for example, or things that Dr. Gross touched on, then I think it's very appropriate to bring up this issue of either stopping or de-escalating treatment. And we will have studies in addition to the DISCO-MS around de-escalating therapies, especially from the B-cell therapies to the fumarates, hopefully in the next few months. Another flip to the coin as far as kind of the same types of questions as far as the efficacy of disease-modifying therapies, the effect of being on a disease-modifying therapy on COVID vaccination. And here, it's mixed news. There's not any published data out there. We started getting data now about 2 weeks ago. And what I can say is it looks very safe to get the COVID vaccine on the B-cell therapies. The efficacy of the vaccine does appear to be a little bit less when we look at antibody responses to the vaccine. We had 10 MS patients and a few others, but 10 that were on rituximab and ocrelizumab that we looked at antibody responses, and only 2 out of those 10 developed antibodies to COVID. And the amount of antibodies that developed were lower than any one of the 10 people that we looked at as a control. Additional patients, though, there was a patient that had COVID and they got vaccinated. That patient developed better antibody responses than anybody else. And what that tells me is that there might be strategies around being able to boost the vaccination responses by maybe having to do booster shots, doing a 3rd or a 4th shot, and things like that. And those are things that we're starting to kind of think about as well. It's also important to realize that, as bad as news as that might be, that there are people out there who make absolutely no antibodies. There's genetic mutations. And there's been reports of some of these patients being able to survive COVID, meaning that the response to COVID doesn't just depend on this. And those parts of things we've not looked at yet, nor have I heard any data, but it suggests that at least that these vaccines are at least efficacious for some people. And because of that, we do recommend getting the vaccine in pretty much everybody. There's a few questions around which vaccines to get. And this is a common one that we're getting in clinic, whether to get some of the mRNA vaccines made by Pfizer, Moderna, or getting the vector vaccine made by J&J, which is the one-shot vaccine. And at this point, the vaccine response appears to be a little bit better with the mRNA vaccines, but to be honest, they were done fairly differently and at different times, so that those numbers may not compare across to each other. And I think it's much more important to be able to get whichever vaccine you can get than worry about small differences in the response to these vaccines. If given the choice, I might go for the RNA one just because of having those 2 shots. And I think that the response might be a little bit better. But again, I think both of them are very safe, and I would take whichever one you can. The other one that we're getting a lot of is around timing of the vaccine to treatment options. For most treatments, I would say do not alter your treatment to fit in your vaccine. The one we talk a lot about are the B-cell infusions. And for these, we are recommending about a 4-week block in between, either to allow between the vaccine and the treatment. I would mention, however, that one of the people that did make antibodies in our study, and not included in those 2, but a third person, had their treatment of B-cell therapy right in the middle of their 2 vaccine doses. And they had a good response. So a lot of these recommendations are very theoretical, and we don't have great data to support what we're saying. So I think it's much more important to be able to get the vaccine than I am worried about trying to time the vaccine. It's a little bit easier to push off the infusions. And again, when I'm talking infusions, these are for rituximab and ocrelizumab. For tysabri, we would not try to push out those infections at all. When do you get the flu vaccine this year, normal time of year? And the answer is yes. Once the flu vaccine becomes available, we want you to be able to get that vaccine as much as can. And I don't expect any delays in getting that flu vaccine out. We saw very little flu this year, thankfully, because everybody was being so careful about wearing masks and washing hands and things like this. So a lot of the things that we had learned from other viruses still apply to COVID. And then questions around the shingles vaccines before getting the COVID vaccine. And I think for this one, the importance is just to get the vaccines. The shingles vaccines is going to be a little bit more available. That's a little bit more long-term, and the risk of shingles right now is lower than that of COVID. And so I would try to get the COVID vaccine earlier if you're going to try and separate them, which I think is always a good idea. But I do have little kids, and I remember easily getting 3 and 4 shots sometimes to our kids all at the same time. And so I think it's quite all right to potentially get both at the same time. I'll finish off my section for the Q&A with a section regarding flares and pseudo flares seen after the vaccine. We have seen some of this. There was a case of a transverse myelitis or an episode affecting the spinal cord after one of the RNA vaccines. We had a patient who was diagnosed with MS soon after getting the COVID vaccine. The patient clearly had MS going a long time ago because on their MRI, there were a lot of not active lesions, suggesting that it had predated the vaccine by a fair amount. So we can see some flares, but I think the number of flares that we're seeing kind of sort of in short association with vaccine are very rare. And so if we're talking about something that happens 1 in 1,000, this is a very small risk associated with the vaccines and things that might have happened in any way. It's hard to associate with the vaccine. It's just one of those things that we say that they, we're not able to say that they're not associated. With that in mind, I would say that the biggest thing that we see are pseudo flares after the vaccine. It's very common to end up with fevers and chills, especially after the second dose of the vaccine. If you did have COVID, we see sometimes that shift over to the first dose of the vaccine. And we had that happen in a couple of our patients. And so with fevers, it's typical to get recurrence of old symptoms. And that's what I mean by pseudo flares or pseudo exacerbations or pseudo attacks. And so that's much more common. The good news about these symptoms of the vaccine, and part of the recommendation, is to have some Tylenol in hand, some ibuprofen, and to take these medicines as soon as you start to kind of have any of those symptoms, any flu-like type symptoms after the vaccines. They're very effective in stopping the fevers, and the fevers pretty much go away. They usually start about 12 hours afterwards and can last maybe 24, 36 hours after the vaccine. And so even though we do see some flares, most of these episodes tend to be pseudo flares. The difference here, just as a big reminder, is that pseudo flares are symptoms that tend to be your typical symptoms. So if you usually get numbness when you're tired, when it's hot outside, when you get a urinary tract infection, that's probably what's going to happen during these episodes after this.
I'll just take the first question. As we age, is there a time when the DMTs or disease modifying therapies are no longer helpful because the MS slows down enough itself? So in a very simplistic way, yes, there is a time for folks at which point we think that disease modifying therapies as we currently have them are no longer worth taking. We don't have a one set time for one particular age for every individual. It's very much an individualized decision that a person makes in coordination with their provider. And so the things that we're trying to look at to see whether it's not exactly a guess. It's I guess we would call it an educated guess as to whether it is safe and appropriate to discontinue a disease-modifying therapy. And some of the things we look at are a person's age and also how long they've had the disease, and then how long it's been since they've had any kind of recent inflammatory activity in their brain or spine. So new MRI activity, new relapses, that kind of thing. And I have a number of very kind of specific questions here of, I am on this DMT for 15 years or that DMT for 20 years. Is it okay if I, would I be a candidate for stopping it? And the short answer is yes, you could potentially be a candidate for stopping it, but discuss the pros and cons with your doctor, with your provider. There were a couple questions about the DISCO MS study, which I think I mentioned briefly in my talk, the discontinuation study, which is a multi-center randomized study where half the group is discontinuing their current disease-modifying therapy and the other half is going to stay on it. It's not blinded. People know which group they're assigned to. And are there any updates? No, the trial is still ongoing. It's not, they're no longer enrolling, but it is still ongoing. People are still, in their respective groups. And so I don't think that we have any more information. I believe he said first quarter of next year is when we're expecting to have results from that study. So stay tuned. And that is one of, I believe, 3 similar studies. There are 2 other discontinuation trials that are actually, I think, still recruiting, but they're in Europe, one in France and one in. Hopefully, these studies are going to help us kind of start to answer that question. And the answer may not be a simple, continue versus stop. There may be another option, what we might think of as something like a de-escalation. So take, for instance, a person who is on a very high, I have a question here about somebody who is on Ocrevus, which is one of our very kind of high efficacy potent medications for MS. The decision might not be stop it, altogether. It might be, okay, well, maybe we treat you with a different medication that might not have the same potency or might not have the same risk for infections and the kind of thing that might increase as a person gets older, or stick with that medication but do it at a longer interval between doses. I think these are a lot of things, and the dose is pretty standard in Ocrevus, but that's not necessarily the case with some of the other medications. So maybe even thinking about decreasing a dose might also be a reasonable option. But these are things that we're just kind of starting to think about and evaluate, but even absent the results from those clinical trials that I mentioned, these kind of decisions are happening every day in the office, where somebody is coming to us and saying, hey, I'm on this medicine, I've been stable for so many years, is it okay if I stop taking this medicine? And oftentimes we say yes, we'll stop. And just to clarify, when we talk about discontinuation, we're not saying okay, see you later, have a nice life, we're never going to treat you anymore. That's not the case at all. We still very much follow people and treat them with other types of medicines for whatever symptoms they have related to multiple sclerosis. It's just that may not include also an immunotherapy. I have a specific question here about somebody whose husband has MS, and they've been on Tech Federa since 2013, but now that Tech Federa has gone generic, the copay is very high from their insurance. This is actually a question that we're getting quite a bit lately, specifically with Tech Federa, and so there's no easy answer to that. So certainly one option could be, well, you're at the point in the disease process where maybe you don't need to be on a disease modifying therapy anymore, and so just stopping it. That might be one option. Another option might be switching to a different medication, and in particular with Tech Federa, besides the generic form, which often now is being required by insurance companies, but then subjecting the person to a high copay. Another option could be one of the newer medications that are in the same class, the fumarate class. So there's a diroximel fumarate, which goes by the brand name Vumerity, which is a very similar chemical to Tech Federa or dimethyl fumarate. And so then switching from one in that same class to a different one, which is newer and does come with some of these kind of copay assistance type programs that might be cheaper for the person in terms of out-of-pocket expenditure. Somebody who was diagnosed 17 years ago never took DMT. Would it make sense to take it now? And now that they're 65, unlikely. We still believe that the disease-modifying therapies are most effective at the very early stages of the disease, and that if somebody has been doing well for 10, 15, 20 years off immunotherapy, then starting it just kind of because it's out there, because it's new and you see a lot of advertisements for it, doesn't necessarily make sense, and is unlikely to be really beneficial and just subjecting person to risk. Medications for progressive MS, for secondary progressive MS, asking about particular medications that have been recently approved. Siponimod, or Mayzent is the brand name, and Cladribine, or Mavenclad, which is the brand name, which have both been approved for secondary progressive MS. There's not necessarily one that we go to in that situation. I think I'll talk for myself, but I think my colleagues as well. We don't just go with one or another. Interestingly, more drugs now have been approved for secondary progressive MS, despite not having had what previously was required in terms of a phase 3 or a large randomized control study demonstrating its effectiveness in that particular group of people. Increasingly, the regulatory bodies like the FDA are saying we can look at things like the class effect or whatnot. And so we're seeing that more things are approved specifically for secondary progressive MS with activity, meaning recent relapses or recent MRI changes. And so, so yeah, there's not one or another that we use. I think, I think it very much depends on the person and the situation, what they've been on before, that sort of thing. Specifically with respect to those medications, I have prescribed siponimod. I have not prescribed cladribine. I think cladribine is probably lower down on the list for things that I would prescribe, because it has some side effects like a risk of cancer, which I would prefer to avoid, especially in people as they get older, where the risk of cancer goes up anyway. And then there's a question about Gilenya and for secondary progressive MS, never studied. And interestingly, Gilenya or fingolimod is in the same class and is kind of the first in class of this S1P receptor blockers, and was not studied in secondary progressive MS, was studied in primary progressive MS, and that trial showed that it was of no benefit. And then around the same time, medication called siponimod in the same class demonstrated effectiveness in secondary progressive MS. And so there are a lot of people who kind of scratch their heads and say, are these two medications really that different from one another, or is primary so different from secondary progressive MS? I think, yes, there are differences between primary and secondary progressive MS, not that many, and there are differences between the two different medications, siponimod and fingolimod. But I think it may just be the case that we're doing a better job of designing clinical trials to show benefits. And in this case, in the case of siponimod, the benefit in secondary progressive MS was fairly modest.
First, one of the questions, or maybe a few, was asking about what is different about when kids get diagnosed with MS, and by kids I'm saying patients, people less than 18 years old, than when adults get diagnosed with MS. We know that by and large, the vast majority of people diagnosed with MS are diagnosed in adulthood. But there is a percentage, and that percentage is maybe 5%, maybe as high as 10%, that are diagnosed when they are less than 18 years old. And what we know from a prior study done when we didn't have good disease-modifying therapies was that kids take longer to reach a point of disability than adults do. So by that I mean when kids are diagnosed with MS, it may take them more years to get to a point of needing to walk with assistance, for example, compared to when adults are diagnosed with MS. But they reach that age of disability, that age of needing assistance to walk at a younger age. So it takes longer to get there, but they're getting there at a younger age because they're starting so early. Now, this was a study that was done before we had highly effective therapies, and thankfully we do now. And so I think the relevance of this is unclear. If we treat early when we know the disease is most inflammatory, we can hopefully change the trajectory of the disease so that that point at which disability is reached, it may be far in the future, if it's even there at all. And again, this is a moving target because we've got great therapies now, but presumably, hopefully, we're going to have even better therapies, 5 or 10 years from now. And so when I talk to families and to patients, I say we need to do what's right now. And we know that when kids are diagnosed, they oftentimes typically have very inflammatory disease. So we have to use a medicine that is really good at calming the inflammatory process. Now, part 2 of those questions that were posed was about cognitive function and what does it mean to a kid who's diagnosed with MS compared to what we might tell an adult diagnosed with MS about their cognitive challenges, what they may be or what they are experiencing. And this is something that is actively being studied in pediatric MS with a study called the Cognitive and Neurobehavioral Aspects of Pediatric MS anyway. So we're looking at kids diagnosed with MS and prospectively testing them at different intervals, and then looking at adults who were within a year or two of diagnosis and testing them at different intervals to look at how cognition is changing over time. And what we see so far, and the data's not all in yet, is that by and large, kids have tremendous reserve in my talk, and I know Dr. Vollmer has spoken to this many times before. We recognize the reserve, the ability of the brain to be resilient against injury and how that changes over time and with disease. Kids have amazing resiliency. And so really early on, they're doing pretty well on these sort of formalized measures of cognitive change over time. But that's within one study. We have other studies that also show that very early on in disease, there are things that can be picked up when compared to controls that are different. And so answering the question is a little bit tricky, but I think the simplest way is to say we do see changes in how kids are performing in school, how they're thinking with pediatric onset MS, but that oftentimes their resiliency compensates for those changes pretty well. Next, let's segue into what can you do to preserve, to enhance your cognitive abilities. And there were some questions about brain HQ, brain teasers. How do we do everything we can to preserve our brain function? And I am reminded of the saying, if you don't use it, you lose it. And so while that was, that kind of term was assigned more to other neurologic disorders, I think it pertains here as well. We really want to challenge our brain in many different ways to keep it facile and to keep it functioning at a high level. And so some of the things that have been proposed are taking a different way home from work, or a new path in any particular direction to get to a goal. There are ample opportunities of crossword puzzles and Sudoku and Brain HQ and apps you can put on your phone. I don't have any particular favorites, nor do I feel that you necessarily need an app, but you need to be doing things that challenge your brain in different ways. And so, yes, I am all for those types of cognitively challenging activities. There was a question about cognitive problems with secondary progressive MS, and I would maybe expand that a little bit more to say just cognitive problems in MS. And I've spoken to that a little bit with the kids and the studies that we're doing to understand that better. But I think that there is undeniably challenges to cognitive function that come as a result probably of the inflammation, and certainly because of the damage, the injury that has preceded where someone is in their course with MS. So the question just says, can I speak to that? I think that acknowledging it is important. I think that fatigue also plays a role in this. I think that we use tools like neuropsych testing to help us better characterize where the challenges are, so that interventions can be customized for every individual. It is something that I think a lot, if not all, of our patients struggle with to some degree, and we rely on tools to help us, to help those patients. And again, any way that you can challenge your brain to sort of stretch and strengthen that muscle, so to speak, will be helpful over time. Now, let's see. So there are some questions about diet, and I did speak about diet in my discussion about, strategies for preserving brain health. Again, like stopping the attack and then fortifying. Diet is a big part of fortifying your castle. There are anti-inflammatory diets. Books have been published on this. I think that they're worthy of a read. But again, the data that we would like to support doing one particular diet is lacking in many of these different diets that are proposed. There is some evidence for the Mediterranean diet. I spoke to that a little bit before in my segment. And again, I think that is something that is sustainable and has some evidence. So has some aspects that you could continue or consider incorporating in your diet. Move on. Is there a connection between MS and Parkinson's disease? Not that I know of. I think that when those two things happen in a family, they're probably unrelated. I have relapsing and remitting MS. Is it inevitable that we'll get to a progressive form? And I think that inevitable is not a word that I would use. I think that our goal is to prevent that, and it's to prevent that with highly effective therapies to every extent that we can. Am I more prone to Alzheimer's dementia because of MS? And no, not to Alzheimer's, but it is possible to have difficulty with memory in a way that an Alzheimer's patient would if the burden of MS lesions is high. And so again, there's a strong argument, a belief, I would say, that we really need to treat using the highest efficacy drug that we have to try and prevent getting to a point of that kind of difficulty.
So folks, there are actually a few other questions that we would like to answer for you, and we'll do this as a group session. The first one has to do with current studies at UC Health, where we work, on remyelination or repair in MS patients. And is there any results or failures? And what do we foresee in the future in this area?
I can touch base. As far as I know right now, we currently don't have any studies looking at remyelination, but we've been involved with a fair number of them. We were involved with a Corda study looking at recombinant human IgM22. There was an AbbVie study that is having its data looked at right now. And Biogen did just announce that they stopped looking into their drug for remyelination as well. We heard about a year ago that biotin was not being effective in remyelination. And so unfortunately, I think we're getting a lot of studies that aren't so far giving us the results that we would like for in remyelination. But I'm sure we'll be part of other studies that come down the line as they come on down the line.
Actually, to add on to that, we actually do have a couple of studies that are coming online. I would say that the argument or the discussion around repair right now is not just about remyelination. It's about allowing the brain to rewire and reconnect neurons in a way that allow people to recover function, in addition to trying to induce some remyelination. And I think the major advance there is not looking just at the astrocytes, the oligodendrocytes that make myelin, but looking at another cell type called an astrocyte that actually appears to be a cell that's creating a environment inside the MS plaque that prevents repair. And one of the molecules that prevents repair is called repulsive guidance molecule, or RGM. And there's an antibody study using an antibody called elimtuzumab that binds to this repulsive guidance molecule and removes it somewhat from the plaque. And in the animal models, that did actually result in some improvement in function, in recovery function for the animals. And so we are getting ready to start in a phase 2 trial, so a large multi-center trial with that antibody. And this is for patients that have disability between an EDSS of 4 and 6.5, which means they have trouble walking, but can walk at least using unilateral support or bilateral support, that are below age 55. And so that is coming up. And I think is a very interesting strategy. In addition, we do have also ongoing, a study that's been ongoing for a while, which is the lipoic acid, which is a neuroprotective strategy. So it's not specifically remyelination, but it is designed to try to improve function in patients. And there are a number of other such studies going on in the world that I mentioned in my talk. But I think that this goes to another question that I'll come up to here, which is, how long do you think it will be before we see repair drugs for MS on the market with the FDA approval? And what is the current breakthroughs in regards to this research? And I think both of those are tied up, again, in this switch from just focusing on oligodendrocytes to also thinking about astrocytes as a key therapeutic target, because astrocytes are the cells that protect neurons and help them survive. They are also the cells that protect oligodendrocytes and help them survive. And in the yin-yang model, they are also the cells that can kill neurons and can kill oligodendrocytes. And this is a bit of biology that's evolving very rapidly right now. And I think that's the major advance that I see in the field right now, is looking at astrocytes as a good therapeutic target. And it turns out that we have a number of drugs already approved by the FDA for other purposes that can affect this biology of astrocytes. So in that model, even in if we started phase 2 trials, which these drugs, we can go directly to phase 2 trials and skip phase 1 because they're already approved. That means we could potentially have a drug that could be in the marketplace within 4 years, 4 to 5 years. So that's exciting. Whether it will happen or not, I don't know. We have another question about any information on hematopoietic stem cell transplant becoming an approved treatment in the United States. Anybody want to talk about the study going on in that area?
I can take a stab at it. There, so our group is involved in a trial called Beat MS. I'm not sure if it's up and running quite yet, although it might be year up and running. Dr. Corboy is the lead investigator on that. And in general, I think, you know, we have gotten, you know, a lot of questions about stem cells over the years. Hematopoietic stem cells specifically are the ones that people generally are thinking about when they talk about that in MS. And these are the types of stem cells that become your immune system. And so the idea here is that you go through a process that kind of wipes out your immune system, and then it gets repopulated with your own stem cells, your own progenitor cells, in a way to kind of reboot the immune system. There have been earlier studies that have looked at this. Many of them have been small or not well controlled or whatnot, but there is certainly some suggestion that it is a very powerful treatment option. On the other hand, it is not without risk, and in some cases the risk might be substantial. Early on, there was a significant mortality in some of these studies. Now that has declined over time as some of these protocols have been refined, and in which you maybe are not completely zapping the immune system to start. Our particular study is looking at people who have not done well with one of our existing treatments, and whose MS has been very aggressive. This has been, frankly, increasingly we see, or I guess decreasingly, we are seeing these type of patients because our treatments have become, in many cases, quite effective, and so we don't see quite as many people having the type of breakthrough disease activity that we used to see, frankly. And so it's a treatment that's out there that's still considered quite experimental because of the risks involved, and we're trying to figure out if it is a good treatment for MS, for whom would it be a good treatment? For whom would the benefits outweigh the risks?
Then to sort of end up here, there's some questions about current recommendations on taking drugs such as metformin or clemastine as neuroprotective agents under a physician's guidance, and what would be the recommended dose. I would say that at this point, I don't believe either one of these drugs should be prescribed to treat MS because we don't have clinical data showing that they're efficacious, and so we can't calculate the risk-benefit ratio. These are still experimental therapies. I hope that they will show promise in the not-so-distant future, but at this time, I personally can't recommend that. Does anybody else have any comments about that?
No, I haven't seen any studies in humans with MS on metformin specifically. I know it is a drug that is in wide use to treat diabetes and other conditions, and so there is a lot of safety data out there, but we don't have a lot of effectiveness data as of yet in MS. in humans. There's a lot of things out there that have been studied in the test tube or in mice that have shown a lot of promise, and this might be one of them, but it's yet to be proven. So it is considered experimental. I agree with Dr. Vollmer. Clemistine, there was a small study, a small phase 2 study, I believe, out of UCSF, and I believe they have another one that is enrolling right now. Clemistine is an older antihistamine agent, which again, kind of in the test tube, seemed to show good ability to promote myelination. And so it remains to be seen whether it will actually do what it is, what the promise is.
Then our last question here is a question I do think we want to address because it is a perception of many of our patients and families about our drugs, which I don't think is correct. And the question is, are there any drugs on the horizon that do not have the serious health side effects of all MS drugs on the market today? And I would argue that the premise of that question is actually incorrect. All drugs have serious potential side effects. In fact, I'd like to ask the audience to guess, what is the drug that leads most commonly to acute liver failure requiring liver transplant in the United States and Europe? That drug is Tylenol or acetaminophen. So every drug has a potential risk for a serious outcome. The question is how likely it is to occur. So our drugs do have potential serious risks, but with many of them, the chance of having that serious risk, something that threatens life, potentially puts you in the hospital, causes cancer, causes birth defects, et cetera, is actually very low. And so the risk-benefit ratio of some of our current therapies is extremely high. And when you compare that to the risk of the disease, untreated or inadequately treated, my own sense is that in my decision-making processes for patients I see in neurology, MS is now the easiest disease for me to treat, particularly in early phase, because our drugs are so effective and they are manageable in terms of minimizing the risk of serious outcomes. What are the rest of your guys' thoughts about that? Particularly Terry in the children.
Yeah, well, I agree. I think that I'm excited finally to have great therapies to be able to offer to the kids and to the adults that I see as well. And what I tell families is we know what MS does. Untreated MS does not look good. So we already know what's going to happen if it proceeds like without treatment. We have great treatments that can shut down the inflammatory phase, which is a very important part of pediatric onset MS. And so I say, let's treat effectively. Let's treat with strong medicines that we know work at a time that we know the disease is very strong. So I agree.
I would also throw in another comment about this in the sense that we're starting to really understand as well what are the risks that increase the risk from some of these high efficacy therapies. And we recently had a paper published with the group led by Dr. Keister in New York. And we often talk about age. We talk about a lot of risk factors where we start to see, concerns for hospitalization and infections. But it's really the disability that increases the risk. So being in a wheelchair for rituximab increases the chances of being hospitalized by 8.5-fold for reasons due to infections and things like that. And so even though we talk a lot about stopping therapies, in older patients, a lot of times we have to look at some of these other things like being male, being prior immunosuppression, length of time, increase the risk maybe twofold. And so compared to disability, there were just drops in the bucket. And most other things like age had kind of actually really fairly low levels of increase.
I agree with, everything that everybody said. I think in general, our treatments are very good in their effectiveness for a wide variety of patients. And the safety concerns are, they're there, but they're usually fairly rare. And with appropriate monitoring, we're often able to avoid them or minimize them. And so this is one disease that really does benefit from having many many treatments that have that high kind of benefit to risk ratio, like you talked about, compared to a lot of the other diseases that we see in medicine, that we see in neurology, where there really isn't much that actually changes the course of the disease, or there is, but the risks associated with those treatments are so severe. In MS, we have a very favorable balance in that sense.
Okay. Well, I'd like to thank all of the participants in the conference today for their time, and thank the observers for taking their time to go through these topics with us. And I hope they were useful. Thank you.